This video is IM nail tibia and ORF ankle fracture. The injury we will be treating is an open diaphyseal transverse tibial fracture, OTA 42A3. The ankle fracture is a comminuted medial malleolus and segmental fibula shaft fractures with syndesmosis disruption. The preferred position is supine with a bump under the hip. A bone phone ramp is used to raise the leg above the level of the contralateral leg for easier lateral fluoroscopy, as well as provide the appropriate amount of knee flexion for the suprapatellar nailing of the tibia. The open fracture site is extended to the extent of periosteal stripping to be able to perform a thorough debridement. Any contamination in non-viable tissue is removed, as well as any fragment of bone that is devoid of soft tissue attachment. Copious irrigation is performed. Once the debridement and irrigation is complete, the open wound is used to obtain a reduction of the fracture. A 2 mm drill bit is used to facilitate the use of a small point-to-point reduction clamp to hold an anatomic reduction. X-ray confirms the reduction of the fracture in orthogonal planes, as shown here. With the fracture reduced, we can proceed to the suprapatellar nailing portion of the case. Approximately 1 finger's breadth proximal to the superior pole of the patella, a midline incision is made. After dissection through the subcutaneous space, the quadriceps tendon is exposed. The tendon is split, and the suprapatellar space and patellofemoral joint is accessed. The cannula is inserted in the patellofemoral joint and aids in the placement of the desired start point in the proximal tibia. Once the pin placement is confirmed, the cannula is secured to the femur to prevent cannula motion in the patellofemoral joint and shear damage to the articular surface. The pin is then cut to make room for the batwing or anterior drop. The entry reamer is used over the guide pin to get access to the intramedullary canal in the desired trajectory. The finger is used next to further make the desired path for the long guide wire to go straight down the canal and also bounce off the posterior cortex. The long guide wire is placed and then confirmed by fluoroscopy. The finger is removed and the length of the nail is measured using the ruler. The need for anticipated syndesmosis fixation is considered in determining the desired length of the nail. Fracture reduction is confirmed before reaming. The tourniquet is also let down before reaming. Fluoroscopy confirms that we ream across a reduced fracture. In this case, cortical chatter was met with the 9 mm starting cutting reamer. Therefore, an 8.5 mm nail was selected. After reaming to 10 mm, an 8.5 nail was placed. Fluoroscopy is used to ensure that we are maintaining the reduction while the nail is placed. Fracture reduction and desired depth and placement of the nail is confirmed using imaging, and the long guide wire is removed. Two distal locking screws are placed using perfect circle technique. Adequate space for syndesmosis fixation is confirmed as well. With good isthmal fit around the diaphyseal fracture and axial stability of the transverse fracture pattern, only one proximal screw is required for rotational control. One screw is placed in the dynamic slot to allow for fracture dynamization later when the patient is made weight-bearing. The open fracture site and tibial nailing incisions underwent a final irrigation and a final closure before proceeding to the ankle fracture portion of the case. Proceeding to the ORIF ankle fracture, the tourniquet was elevated after Eschmark exsanguination. The approach to the ankle will be through medial and lateral incisions, and we'll start medially first to address the median malleolus fracture. Careful dissection is made to avoid the saphenous vein and nerve. Flaps are mobilized through the hemorrhagic tissue and down to the periosteum and fracture. The periosteum is incised and elevated around the fracture. Fracture hematoma is removed, as well as any interposed tissue, such as periosteum seen here. In exposing the fracture site, it is important to elevate the periosteum at the fracture edges to be able to judge the reduction by the cortical read. The anterior and medial cortical reads are helpful here to obtain an anatomic reduction. After reducing the median malleolus with a point-to-point reduction forceps, my first attempt at fixation was using a 3.5 cortical position screw. However, when placing the screw, I felt that I lost reduction. Therefore, I removed the screw and re-reduced the fracture and placed the provisional K-wire. To ensure screw placement, I used a fluorocannulated screw. When placing the cannulated screw, the median malleolus fragment started to rotate. Therefore, I backed off the cannulated screw, re-reduced the fracture, and used a 2 mm mini EVOS plate to buttress the rotation, and then advanced the cannulated screw. After the cannulated screw was fully advanced, a second locking screw is placed in the median malleolus fragment. Copious irrigation was performed, and closure was completed in the standard layered fashion. Nylon is used to close the skin. I made a lateral incision directly over the distal fibula. I dissected through the subcutaneous space and down to the periosteum. I dissected anteriorly to directly visualize the anterior distal tibia-fibula joint to assess the reduction, while pulling the distal fibula distally with a point-to-point reduction forceps to help restore the proper length. I also used my thumb to push the fibula into its seated position in the incisura. A provisional K-wire was placed to hold this reduced position. For syndesmosis fixation, a 2.7 mm mini EVOS plate was used. Two screws would be placed approximately 1.5 centimeters above the joint line. The first is placed parallel to the joint line and angled approximately 30 degrees anterior. A second screw is placed parallel, however slightly posterior to avoid hitting the nail. Final films of the ankle and tibia fractures are taken. Copious irrigation is performed, and closure in the standard layered fashion is completed. Nylon is used to close the skin. After the incisions are cleaned and dressed, a splint is placed for soft tissue rest and pain control. The patient is non-weight bearing. At the 3-week follow-up, the patient is doing well, sutures are removed, and physical therapy is started to restore range of motion. Protected weight bearing is maintained. At the 9-week follow-up, the patient continues to do well, range of motion is restored, and the patient is advanced to weight bearing as tolerated in a CAM walking boot.